and the learned audience. Assalamu alaikum. Already all of you were exhausted. But at the beginning, let us look at the factors, that is, quality and safety issues in maintaining proper use of medicine at the community level. First of all, let us assess that what is the magnitude of the problem. If you look at the WHO estimate, we find that almost half of the medicines are being used inappropriately and sold or dispensed inappropriately and or taken incorrectly. If you extrapolate this data on other situation, what we see, approximately last year, 7,000 crore of medicine was sold. If half of these are sold or used inappropriately, that means 3,500 crore of medicine was prescribed, dispensed, or sold inappropriately in last 1 year. 50% patients take the medicine incorrectly. In last 1 year, according to the government data only, approximately 4 crore and 40 million patients enter or encounter in the outpatients of the government facilities. Only if half of them have taken the drug incorrectly, that means approximately 2 crore patients have taken their medicine incorrectly in last 1 year. So, how do we feel about it? Approximately 3,500 crore medicine prescribed inappropriately, or approximately 2 crore patients have taken their medicine incorrectly. I think that the issue is important. So to this issue, this session is only focused on the use of medicine at community level. Medicine are being used at two levels approximately. One is at hospital level and the other is at community level. So in this connection, it must be mentioned that how the drug will be used at community level is principally determined or influenced by the drug that is being used in the hospital. So these are the different issues or aspects or the points at which drugs are now being used in Bangladesh at community level. These are a top line of times these are being used at the hospital, present in the community, that contain the community hospitals as well. So if you look at the term, we have used a proper use of medicine. So there are lots of terms related to this proper. One, our common one is rational. There are some other words like correct, proper, appropriate, prudent, responsible. There are different terms used interchangeably. So for this purpose today, we are taking proper as a all-encompassing term that will include all these issues. So how people take drugs in the community? They may take the drug in accordance with the prescription. In this connection, we must explain that prescription means here in Bangladesh, it can be generated by a qualified physician, but it can also be generated by anybody like a paramedic, medicine seller, health worker, or anybody who can write. They can generate a prescription. So written prescription does not mean anything in Bangladesh. There is another option, people take drugs in accordance to the verbal instruction. That verbal instruction might come from friends, family members, neighbor, anybody. And the other option is self-medication, that is on own experience. For the risk that is associated with, we usually take it for granted that these are only for benefit. So the billion-dollar question is, should we continue with this kind of seminar workshop? This is the famous shift. All of us know about this. This is staggering. And we know about the sad story. But possibly this is thing we don't know. Just before the crash, there was a shout from the much Irish Park. And from the starboard they were planning that, well, we're in the middle of a conference on Irish Park avoidance. So what should we do? Should we continue this kind of discussion, or should we immediately intervene? Regarding this quality and safety, what we think is we are just clashing with our path. Thank you very much.
Thank you very much for participating in this. So here is the organization in US, Students of Abraham. They are doing similar work we are giving medical supplies to the developing countries. So I was involved in one of the shipments with a 40-feet container, which we have to bring from our Chittagong port to Dhaka Medical College. And we have found some things that are usable, and there are some things in the US that electricity voltage is 110. Here we have 220 to 240. So this is one thing we have faced difficulties. We have to make an adapter to use those, and again we have 100 infusion pumps. Very happy we have distributed all over the department, also outside of our Dhaka Medical. But then found that there is a special saline set, so we could not use none of them. Those are very expensive. I think each one more than $100,000 or something. This is one experience we have faced. After that, we have received another X-ray machine. Came from Austria. There is another organization, Switching Moy Foundation. So they also do these things. They give supplies, medicine, volunteers. That X-ray machine, now more than 18 months, we could not install. It is in part by part, so the technician they could not install. It was done in last 3 installations, 96, after that they did not produce. So we could not do. So I request you, whenever you are going to distribute this thing, it is also if you want to help when you are giving, but there are some other problems to make that workable. And again, this money, $2,000 I have to spend from Chittagong Port to Dhaka Medical College. I have to arrange this myself with my friends and support. So please, important is the issue. Just don't distribute. That those things should be usable. I'm sure we're going to take care of it. My friend and colleague, Ashafullah Khalid.
What we have in the country, but my request is to reaching out to how can we reach all the information to the district level and all below. So this is very important. That's my comment.
Okay, thank you. Yes, last one. Please.
Professor Saibul Rahman, so I was in the last part of the discussion. So my question is that actually in our country, particularly in the rural area, the technician leaders, before they have been prescribing the latest antibiotics, it's still not. So how to prevent it actually? It's so to prevent it, but how to prevent it actually? I have to know actually. Thank you.
All right, let's start with the last person. So the Pythagorean prescribers like Kulak and others will now transition their urban community, so we can start within an urban population, buying this 3 or 4 drugs, that is an antimicrobial, tablet, narcotic analgesic, in a city like Dhaka or Chittagong. So people will have alternatives and we can enforce that. Because we know that almost 70% of the rural population now taking medication as one other than the graduate physician. So right at this moment we cannot enforce it. So we should have enforced it gradually and we should start with the bigger cities where people have alternatives. So I think that would be a good start.
সেগুলো কিন্তু আমার এই অডিয়েন্স এইখানে বসে এটা বলার কিছু নাই। বাংলাদেশের পরে কিন্তু গরিব মানুষ বড় করে না। অতএব আমি ওনার সঙ্গে একমত, আমাদেরকে এটা গ্রামে গঞ্জে ডিস্ট্রিক্টে এই মেসেজগুলো পৌঁছে দিতে হবে যে মানুষ যাতে ভাবে।
Thank you. Now,
with regards to the equipment, it's not being very ethically responsible to send you something without the appropriate supplies and the appropriate education and the appropriate plus. Because when it arrives, you're not able to use that particular machine. And there are many organizations in the United States, as you indicated, that send medical supplies overseas. And what we do in partnership with World Health, before we send something like that, we need to look at the plug. We need to make sure that this particular item works. That it didn't come into the warehouse, it's sat there, and then we're going to ship it off. We're not going to send you anything over here that is expired or that does not work. That's our personal responsibility. The other part of that question is, if we send you a mammogram machine and it works, and you put that mammogram machine in a district hospital, but you do not have the services that go along with diagnosing breast cancer and follow-up treatment, that's also the wrong thing to do. We need to create services that address needs appropriately. And regarding the cost of bringing medical supplies and container loads, shipping container loads throughout the world. It's expensive. It's definitely expensive, and we at Partners for World Health cannot bear the entire burden of the cost of shipping this. So it has to be a collaborative relationship that we develop with our partnering organizations in the country where we want to help, where we can come to help you.
Thank you.
I would suggest that you look at your cell phone companies. Those cell phone companies weren't around here 15 years ago, and they weren't making any money. But guess what? They are making a lot of money today. And we ought to reach out to some of the cell phone companies here in Bangladesh and ask them if they would support us in helping to pay for the shipping of these medical supplies to your country.
Sure, thank you very much. Now it's time to Dr. Indra Shah.
With all the speakers, I actually communicated all the speakers, and they were talking mostly the clinical things. So you know that all this clinical intervention has a public health approach and has a public health perspective, and that's the way we should be looking at all of these issues. I mean, the Professor Samantu was talking about burns, and then Professor Kajol was talking about the pediatric surgery, and then Professor Saifur Rahman talked of drug use. And at the beginning, Elizabeth talked about the difference in supplies and drugs. I mean, all of these for health, I mean, these are clinical interventions. And clinically, we need to make the people safe and sound. But the
Thank you. Now it's the time for the chairperson of the session, Mr. M. Abdullah, Additional Secretary, Minister of Health and Family Welfare. Please, I would like to request him to make his deliberation and conclude this session. Thank you.
Respected Chair, Co-Chair, respected visitors, distinguished participants, good afternoon. I qualify for practicing the preventive and clinical care. Actually, I'd like to have not an expert. What I'm saying is not an expert in conservation remarks. What I'm saying is relevant remarks. Because I'm not a physician. There is a very popular and known phrase which everybody knows, and we have used here. Yes, prevention is better than cure. We are talking about prevention, safety, quality of safety, practical preventive and clinical care. Actually, this very phrase that is the prevention is better than cure, we believe it. Okay, there is any patient, we believe it, or we don't believe it. We believe it. But the question is that, do we practice it? Yes, there is patient in that way. To what extent we practice it? We believe that, yes, prevention is better than cure. In clinical aspect, well, again, you can't say clinical form, that is the curative.
Okay, the announcer is gone.
Well, that is finished right on time. I was supposed to 1 hour, so I have many slides, but I'll skip, and now we're 8 minutes. My topic is actually health care for the elderly in Bangladesh, in needs, challenges, and schools. I'm a geriatrician, and so that's my topic. So why are we talking about geriatrics? when we were talking about development. We have heard yesterday in one study, university teaches that there are increasing number of older population in London. In each one of the sectors of health that we work. So there are actually three aspects why we think the health for the elderly is very important for the community. One, first of all, is the biological change. We have physiological changes that occur in our body as we get older. These are not diseases. These just happen as a process of aging. And these are different than regular traditional adult medicine. And that's why we do that. The next topic we will talk about is population dynamics testing and the social demand that comes with these things. For the biological changes, in comparison to the traditional adult medicine, think about a 30-year-old woman who will come and say, I have increasing urinary frequency, or low abdominal pain, or dysuria. And you think about this urine. Did you do a urine test and you diagnose it? As simple as that. So there is a sign, symptom, and then there is diagnosis, and then there is a treatment. In older adults, usually it doesn't happen this way. They're not going to come and tell you I had increased frequency. They do not have additional symptoms. So what happens is most of my patients will come to the hospital after a stroke. They have a brain hemorrhage. Why? Because they're scared. Why? We don't know. Or they're confused. They have delirium. They have alternate level death. Very common diagnosis for older patients to come to the hospital or to stay. And you find out that they have a urinary tract infection or they have an MI. There is no connection between the symptoms and the underlying diagnosis. Well, there must be a connection. We don't know how it happens yet. But this is why special training is needed for the physicians to recognize these symptoms and know what's going on underneath. And not just go for the stroke only, but the underlying pathophysiology that is going on. So why does it happen? Homeostasis is a process. And let me explain to you. If you look at the graph on your left, if you think about age 1 here on the left side and age 100 to the right side, these up and down arrows will show you how much physiological reserve we have as a 1-year-old child to fight any infection, injury, anything that happens to us. That's why you will see a 2-year-old will run around with fever and his mother is worried, right? But as we grow older, the graph on the right side will show you we are living off of our physiological reserve. So there is very little left to fight. So what happens when they have a urinary tract infection? They are so sick that they need to be hospitalized and they may or may not make it, depending on how soon we should address it. So this is a continuous process, and this is what happens as we get older. These are the biological changes, due to biological changes or physiological changes. You will see from age 25 to 85, there is 130 times increased risk of death. This is a process of decreasing capacity. So you will see in the kidneys, we have to adjust for medication, renal doses for medications in older patients, not because they have kidney disease, but because of their age. And so I have 2 minutes. It's really not fair, but let me go to my next population dynamics. So you have learned that biological changes happen. Population dynamics. The older people are increasing in number. You see this the pyramid on the left side that is showing the pyramid at the current time, which is changing. And with this change, what happens is people will have expectations from the medical institutions, from the medical professionals to give service to them. So we have to really do service, but how do we do that? We have to educate our health professionals and do it by research. So we have to have health policy, we have to have public health awareness, we have to have the clinical medicine track, and of course research and development, because we have to develop our own evidence-based medicine. So she was taking blood pressure medication. She ran out about a week ago. Does this tell you that she needs blood pressure medication? Probably not. So she did not know. There was lack of continuation because she moved from one state to the other. She did not have a physician for a while. So she ran out of her prescription. So after a while, we found out that she doesn't actually need any of those medications. We needed to pay for this. So I just wanted to show you that this case, we could give her the quality of care, and then she started continuing the care with me because we could provide, we have a medical record. Now, if you think about a patient coming from a village or even going from a private practitioner from district to next district, we do not have medical records to carry with us. Patient comes and says, I have a headache. Is this a headache that she had last week or not? We do not know. So, to provide this, we again have to work with the interprofessional team for the older patients. Scope, because there is almost none. So, thank you.
Thank you very much. As you know that our average life chairperson Bangladesh basically foundation will talk of this topic. Role of civil society to improve health is in Bangladesh.
Ladies and gentlemen, I first express my acknowledgement and gratitude to the organizers of this conference to think of me and inviting me for this talk. Although I must agree that I am not an expert in the field that they have asked me to do. Since I worked for some time with government and other health systems, I'll be able to put some light on this. Mr. Chairman, Professor Nuri will be Vice President of the DCS APN Bangladesh Civil Society. Professor Dr. Sahani, the General Secretary of Civil Society on Nutrition, and many other distinguished speakers from home and abroad. Thank you very much, and just not tax your time, but let me share my thoughts with you on this area. What is a civil society? This means that this term civil society is different by different group of people. It is sometimes considered to include the family and the private sphere, and referred to as the third sector of the society, distinct from the government and the business groups. The government is the main health system holder, and the business group has different interests that they are product close to. The civil society is in the middle. Let me show you more details on that. In this view, the civil society refers essentially to the intermediary institutions, such as the professional associations, religious groups, labor unions, citizen advocacy organizations that give voice to various sectors of society and in this public participation in democracy. And these are the development of civil society. This graph shows you over the years from beginning almost from 1960 up to 2007, there is over 400 civil societies in this country, including profit citizen organizations. This is a comprehensive list of groups who can claim themselves in the civil society. Mainly the academic group, activist group, charities, civic groups, and the churches, cultural groups, social enterprise, policy institutions, and the foundations, men's groups, women's groups. So they all decide they represent the public of this country. This is generally the role is that this is the worker, the third independent group or visionary. Visionary is a broker. So I said the one is the third independent group. They do program analysis, academic evaluation of things going on, government awareness driving, attend meetings and contribute to policy and program development, and the support health system that is done by the government.